Welcome, everyone, to another Miles4Hips interview with a US-based pediatric surgeon, Dr. Sankar from CHOP. And my name is Ashley Spalla. I am the Information and Resource Development Chair for Miles4Hips. And Dr. Sankar, would you like to briefly introduce yourself and what your current position is?
Sure, Ashley. Thanks for having me on. My name is Woody Sankar, as you mentioned. I'm a pediatric orthopedist. I work at the Children's Hospital of Philadelphia. I'm director of the Child and the Young Adult Hip Preservation Center. So I take care of infants all the way up until patients in their 40s or early 30s into 40. I do a host of pediatric and young adult hip conditions. So I take care of dysplasia, both in babies and in older patients. I take care of a lot of patients who have Perthes disease and slipped epiphyses and so on, and a host of other things, Down syndrome, lots of different skeletal dysplasias and so on. I've been at CHOP for 15 years, which has been really a wonderful place for me to grow my practice. And I'm pretty involved in a lot of international and national study groups related to hip research. So that includes the Anchor study group, which is a hip preservation group, the International Perthes Study Group, which looks at obviously Perthes, and then what used to be the International Hip Dysplasia Institute and is now the Global Hip Dysplasia Registry, which looks at infantile hip dysplasia. So I've been involved in research at a lot of different levels and enjoy that as part of my practice, and obviously enjoy taking care of kids and young adults.
That's amazing. Why did you end up pursuing pediatric hip preservation as well as adults?
Yeah, so I think there a lot of times when I interview medical students and residents and fellows, they have their life kind of mapped out ahead of them, and that was not me at all. I was born to two engineers, and so when I grew up and I had an affinity for math and science, I kind of thought, you use that, you go to be an engineer. That's what you do. I had nobody in my family that were doctors. And so I went to college thinking I'd be an engineer, but then kind of 3 years or so into college, really actually relatively late. I was never pre-med or anything, but had done a lot of scientific coursework because of engineering. I had friends of mine said, "Hey, you ever thought about going to med school?" Because I wasn't really super enthralled about some of the job opportunities and some of the things I could do with my degree. I was A lot of the prospects would have been around like computer semiconductor processing, and that really wasn't super exciting to me. And so friends who knew me said you should think about doing this, and so I kind of went to med school on a whim. I didn't know that I would really love it. I said I'll try it out, and if I don't like it, I'll do something different, and fell in love with it. Growing up, I always enjoyed kids. So I was that kind of strange teenage male who would be like the male babysitter. There's always like female babysitter around, but I was like the one guy that would love to babysit kids. And then I was that camp counselor at sports camps and things like that. So I loved working with kids and being around kids. I even volunteered at daycare centers when I was too young to have a job, but it was kind of down the street from my mom's office, and so she needed a place for me to go, and so I kind of worked there. And so I always enjoyed working with kids. And so once I kind of realized that I was going to med school and started to kind of marry my interests together, I thought I was going to be a pediatrician. I really did. I was like, I love taking care of kids. I like medicine. This obviously I'll be a pediatrician. It's going to be great. And in med school, you tend to you do your coursework and then you do your clinical rotations. And most people will do the ones they really want to go into later because they kind of want to learn how to be on the wards and how the whole med student thing works. And so they'll wait and like save their quote unquote important rotations to the end. Well, I did surgery first because I was like, there's no way I'm going to be a surgeon. I was like, I'll get it out of the way because it's going to be terrible. And I just loved it. I fell in love with it. I fell in love with the fact that I could use my hands and do things to help people. I think that probably comes from my dad being an engineer and doing a ton of stuff working on cars, and me growing up underneath the chassis of the car and working around the house. And so I decided I really liked it. Then the question is like, what was I going to be? What kind of surgeon? And I think because I was mechanically inclined as an engineer, and then obviously wanted to work on people, that kind of orthopedics was the natural fit. And so the two kind of came together. It was like I was kind of all of a sudden becoming my father's son at the same time that I was, going on in practice. And so orthopedics I was like, but when I was looking at all these specialties, I was looking at it through the lens of children because I always like kids. So then I started saying like, well, what kind of pediatric surgeon do I want to be? And I was like, I looked at pediatric ENT and I looked at plastics. But again, as I mentioned, I came around to orthopedics. So as is always the case, you really get influenced by a couple mentors that interact with you at certain really key portions of your life. And for me, it was a guy named Dennis Drummond, who was the former chief at Children's Hospital Philadelphia. And so I met him and I was like, this guy's awesome. I want to be like him. And so, I went into orthopedics with always a plan to be in pediatrics. So then fast forward, finished pediatrics and how did I get involved in hips? The time that I was training was kind of 2005, 2006. And there was this huge explosion. That's when Reinhold Gans had gotten up to speed with the periacelular osteotomy. It's when this procedure called the surgical dislocation, which really allows us to do really amazing things in hair preservation, was like just in its infancy. And so I kind of was like the right person at the right place at the right time. This was starting to get interest, but there weren't a lot of people that had kind of figured it out in the U.S. at least, and a few people had in Boston and so on. Mike Mills, of course, who was well known, and so I said, this is really neat. Like I just saw it, and I said, this is just such a cool untapped area. I kind of want to be a part of this new area, this new growing idea or concept of preservation. And so very early, got interested in it. You have to, there was very few people doing it now. There's somebody in every city doing these kind of operations, but 15, 20 years ago, there wasn't. And so you really have to put the time in and either go to Europe or I spent a year or 6 months with Mike Bellis. And so did some additional training and learned this stuff and then brought it to Philadelphia. So I just like that it was, and I still like the fact that it is kind of not entirely worked out in the sense that when we do research, I feel like I'm meaningfully contributing to figuring stuff out. Whereas no harm to my sports colleagues, but like there's a lot of research on the ACL. There's just tons of research on the ACL, and
Absolutely.
that surgery is pretty well worked out. And there may be some nuances, but it's pretty well worked out. Whereas hip preservation, patients may not love to hear this, but we are still learning and we are still evolving, and we're trying to improve our diagnosis and our surgical treatments and our decision making. And as a clinician, patients again don't love that because they want the answers to be fully understood and known. But for people like me who are really investigational and academic about this, like that's what makes it better. We want to make it better. We want to figure it out. It's not an answer that's totally known. And so that's what was exciting for me when I entered. Obviously, there's a lot more that we know now than we knew 20 years ago when I entered. But there's still some lots of questions to be answered, which is really what makes it exciting.
Oh, absolutely. I had my PAOs in 2009 and 2015, and just between the two differences,
There.
there was a huge difference between the two
Yeah, and
surgeries
it's
and
exciting to be
recovery.
a part of making something better,
Yeah,
like seeing the real difference in how I practiced when I started and how I practice now. Like we are doing things better, and hopefully in 15 years we'll be doing them even better.
that's amazing. And as a patient that's had complications, that's amazing to hear that, um, for the future, um, for the future generations. Um, what symptoms would lead a parent to suspect their child has hip dysplasia?
Yeah, so because I take care of this huge spectrum, I take care of a lot of babies and I take care of a lot of 25 and 30-year olds. And it really is different, right? It really depends on where you are in that spectrum. So, any mom out there who may be listening to this who has babies know that the pediatricians are always checking the hips, right? They're looking for hip dysplasia and they're feeling for clicks of ups, and they're not asking for symptoms because it's a baby, right? So there's no symptoms to really kind of there. You can feel a hip maybe being unstable, maybe, but you're not going to get a report of symptoms. Very different than a 25-year-old woman who is saying like, I hurt when I work out and so really depends on where you are in that spectrum. So the typical complaints or symptoms for, I would say, skeletally mature patients, so teenagers and above who have hip dysplasia, is typically pain. Okay. Sometimes there's a limp, sometimes there's a little bit of like early fatigue, but the most central symptom is pain. And the pain is typically in the groin. It can be in the front, what we call the anterior part of the hip. It can be down the thigh a little bit. It can be a little bit into the knee. It can be on the side, which we call lateral base pain. That's the kind of typical symptomatology. It's very activity dependent, which means that the more you're up and on it, the more you walk, the more you run, the more you work out, the more it hurts. The more you sit down, take a rest, lie down, the better it feels. So it's very dependent on the activity that you're doing. Some patients will have some popping or clicking. Some people may have, if they're a labrum, which is the kind of O-ring that kind of seals the joint, which is kind of an innocent bystander in the whole dysplasia pathology, but the labrum can sometimes be injured as part of the whole mechanics. And that can lead to kind of like a sharper pain, but it's typically kind of this kind of dull, achy, kind of activity related pain. In infants, as I mentioned, they typically have no symptoms. If they have a dislocated hip, or if they have a hip that's kind of partially out of the socket, which we call subluxed, they might have a limp when they start to walk. It'll usually be a painless limp, but then the pain will pick up later in life, depending on the weight and their activity level. They could be 8, 10, 12, 15 before if things start to hurt. But but yeah, so it really depends on where you are in that spectrum. It is typically pain later. It is more, I would say, lack of a better word, deformity or limp, or leg lengths being different earlier in life.
Now, how accurate is the hip click or Ortolani test in babies?
Yeah, it's a great question. So, this is a topic that I get asked to kind of weigh in a lot in terms of guiding pediatricians for this. So, the first thing I would tell you is that the hip click and the ortolani are two different things. And this actually, depending on how deep you want to go down this rabbit hole. So, when Ortolani came over or his treatise got translated over from Italian to English, it actually got mistranslated. And so he meant clunk, but it got translated over as
Oh,
click. And so that has led to a lot of, I guess, poor communication when it comes to this pathology. So a clunk, feeling like something is like a deeper thud, like something clearly moving in and out, that is always pathologic, and that is real. So if you feel it, it's real, and you have to kind of deal with it or so on. Okay, that can be distinguished from a hip click, which I tell people it's a little bit like cracking your knuckles. Like it's a higher pitched, painless little click or a pop. And that is often completely meaningless. So the challenge is the pediatricians say there's a hip click, but the question is it a benign hip click or is it a clunk? And those are not the same things to an orthopedist, and certainly from the original descriptions of this. So a clunk, like something popping in and out, I tell my residents it's like something moving over a speed bump. It's kind of a low grade thud. That is a problem that should be addressed and can be very easily treated non-surgically early in life. So I don't want people who are listening to think that, like, oh my God, we have to go right to surgery. It's not. It just needs to be identified, diagnosed. It can be treated very nicely. The click often gets followed up on. It's a reason why people get ultrasounds, but the click is usually benign. And so the predictive value of the click is not as much as the predictive value of the orthogonal. Now, the other question you're getting to, which I think is a really important question, is how good are we at physical exam of picking up hip dysplasia? And one of the challenges is that physical exams are really intended to pick up a dislocated hip. So if your hip is popping in and out of the socket, then the examiner is ideally feeling that translation in and out of the socket. Okay. But there are lots of forms of hip dysplasia in which that is not the case. So, for example, a dislocated hip that is stuck, it won't go back into the socket. Well, if you move that hip, you're not going to feel it clunk because it's stuck out and because of various reasons, it's so tight it won't come back in. Now, usually you can tell the hip's not moving very well, but that's a scenario where there's a negative Ortolani sign, but it's still a hip that's got issues. More common is a situation where the hip is in the socket. It's not dislocated, it's just shallow, right? That's what dysplasia is. That's the type of hip that grows up later to potentially need a PAO like you did. Okay.
mhm.
So that is not going to be picked up on physical exam because there's no dislocation, there's no popping, there's no in and out of the hip in the socket. So physical exams cannot pick up dysplasia. They can only pick up dislocations and probably not even all dislocations. And so our screening methodology is really intended to pick up dislocations, which are the most severe form of DDH or developmental dysplasia of the hip, but they are not the most common form of developmental dysplasia of the hip. The only way to pick it up early in life is to screen everybody with an ultrasound, which there's been lots of appropriate use criteria, a lot of like large studies done to figure out U.S. Preventive Task Force, is it cost effective? And at least with today's data, most, again, not me as a hip person and not, all of us that live in this space, but the people that make these policies say that it is not cost effective, which means that the ultrasounds are not routinely ordered.
Makes sense. Now, how do pediatric hip dysplasia treatments differ versus adult treatments? So, like the 14 and under versus 14 and over.
Yeah. Yeah, great question. So early in life, which I would call early in life under about 18 months, certainly under a year and definitely under 6 months, we can treat most hip dysplasia and even dislocations non-surgically. So a brace, a harness, there's lots of different braces used. I use 5 braces in my practice. It is more than just the Pavlik harness. There's tons of braces out there around the world. A lot of them have very good track records, and maybe in North America it's typically the Pavlik harness, but you should know that there are lots of braces out there that are equally effective, and I use lots of them in my practice just based on what's the right fit for that patient and so on. So we can typically treat both dysplasia, which in that term means shallowness, or a dislocation with braces. After about, depending on the severity, a year, year and a half of age, those things become less effective. And then we start moving into surgical treatments for infants for dislocations. Okay. We typically don't treat shallow sockets surgically at that age. We do treat them with the harnesses and the braces early because it's obviously non-surgical. But if I see a 1.5 or a 2-year-old with shallowness, dysplasia in the socket, I don't necessarily recommend surgery because some of those patients will get better as they grow up. And part of my job is figure out who I think will get better and who maybe won't. So we treat dislocations right away as soon as we know it. But if we move into the world of, okay, not dislocations, we're talking about just shallowness or dysplasia, then I think of it as kind of 3 windows of treatment, or maybe 4 windows. Really early, braces and harnesses. At age 3 or 4, there are smaller pelvic osteotomies that are relatively straightforward to do, take about an hour to do. These are your procedures called a Salter procedure or a Pemberton procedure. There's different words that go with them. There's different types of them, but they basically involve slightly bending down the socket or making a small cut and rotating the socket, but they're relatively quick, fast healing procedures. They often go with the cast because we're still talking about kids at the age of 3 or 4. Once you get to age 6, 7, 8, those procedures are not really powerful enough to create the change in the pelvis that you're trying to achieve in most situations. And so then in those age patients, if we have to operate, meaning that we're starting to see the hip kind of pull away, or that's really severe shallowness, or the patient's symptomatic, then we often do what's called a triple pelvic osteotomy, which is, you could think of it as a PAO in a younger kid. It's really similar to a PAO. The cuts are slightly different so that they don't affect the growth plates, but it's the same concept. You're cutting around the socket, you're moving the socket, you're fixing it with screws. That's still a very similar thing. And then depends a little bit on the age of the patient, how mature they are, but somewhere around, again, depends on the surgeon too, 11, 12, 13, 14, somewhere where most of their growth is behind them, we start switching over to PAOs to fix shallowness or dysplasia. Again, this is assuming the patient needs to have surgery. It's bad enough. Their symptoms are bad enough. It's obviously not everybody who has dysplasia has to have surgery. But if patients are symptomatic enough, if they haven't gotten better with physical therapy and so on, and we're talking about surgical options, then it is typically the PAO after patients have done most of their growth. So 12, 13, 14 in a girl. And then it's the
Okay.
same treatment in a teenager as in a 20-year-old. So people will say to me, like, you're a pediatric orthopedist. What are you doing taking care of a 35-year-old? It's the same operation in a 15-year-old or a 35-year-old. So, I do them a ton in teenagers and 20-year-olds, and then doing it in a 30-year-old is the same difference.
I mean, you already answered my next question, which was what are the different types of osteotomies in
There you go.
kids and adults? Which was great. So that was awesome. Um, Now, can you tell the difference between um, what a osteotomy is and the PAO, how they differ?
Can you
Are
say
they
the first one
used
again?
more?
The what kind of osteotomy?
is it the BIPO, like the BIPO osteotomy?
Oh,
Um, is that used more in Europe or is that
yeah, I
more
think
in
it's the
adults in
Birmingham
Europe?
osteotomy.
Yeah,
Yeah, so it's a similar concept in that you're still cutting the socket free. When the word PAO, it's actually a generic word. It just means periacetabular means around the acetabulum, and
mhm,
osteotomy means cut. So actually the triple is a PAO because you are cutting around the socket and then you're moving it. So the generic word is a PAO. So all of these things, whether you're talking about like the old dial procedures or a Wagner procedure, or some people talk about the spherical osteotomies that are done in Japan. Those are all PAOs. So if we're being really precise, the Bernese PAO or the Gans PAO
yeah,
is the what has become interchangeable with PAO, at least in North America. So if you say,
yeah.
"Oh, I had a PAO," people are really talking about I had a Bernese or a Gans PAO.
Gons osteotomy. Yeah,
Yeah, correct. But there are different PAOs, truthfully. They are different ways that the cuts are made around the socket. And so that's another example of that. The dial is another example. But so slightly different tools, slightly different access points, but the concept of cutting around the socket is the same. Now you may say, well, why is that any different? The elegance of the operation is you are trying to create motion and get this socket to be really mobile so that you can put it where you need to be. But there are the way the cuts come together, like the more polygonal and kind of sharp the corners are the cut, sometimes the less it moves. So that's why originally it's a little more complicated. But the spherical osteotomies that made like a rounded cut all the way around, they're a little bit harder to do to get all the cuts to connect. But then you have like a dome, which actually is very easy to move and control, rather than like a polygon, which is kind of what the Gans PAO. So long story short, to get too technical, but long story short, there are all a PAO is cut around the socket. There are different ways to achieve that. The triple is one way. The Birmingham is one. The Gans PAO is another. The dial is another. There are a few. The Gans is by far and away the most popular one these days, but there are other ones.
so well, thank you for explaining that. Um, and bringing back those Latin lessons. Are there genetic or hereditary components of hip dysplasia that you can speak on?
Yeah, there are for sure. We do know that family history is an extremely strong risk factor, and in fact, family history alone is one of the factors that will want to say allow, but will often suggest to a pediatrician to order an ultrasound in the daughter of a patient that has hip dysplasia. So we do know that family history is a well-established risk factor for hip dysplasia, and we do know that there's been some work done, several different labs that show there are genetic markers for hip dysplasia for sure. Now it's not as simple as certain diseases where you get one gene that is a hip dysplasia gene and you get it. It's kind of a multifactorial process, a little bit like kind of eye color where there's a lot of different genes that feed into this final thing of dysplasia. And then even within that, there's what we call variable penetrance, which means that the same genetic profile, somebody might have mild dysplasia and somebody might have severe dysplasia
Right.
just based on how it manifests in that person. And there probably is, although we don't have a great sense of this, but there probably is some environmental factor based on maybe how active you are early, whether you do a high flexibility sport. I mean, that's all a little bit conjecture, but I suspect there's probably, like all things in life, there's usually some environmental factor that people have two sets of genes, but this environment pushes them a little bit down in this direction, another environment pushes them in the other direction.
If a parent or caregiver has a family history of hip dysplasia, how would they get their child screened if they have like an infantile child
Yeah,
or young child?
yeah. So ideally, the pediatrician is taking that history and on their own, him or her is saying, "Hey, listen, we should get an ultrasound in your child," but that may not always be the case. And so I think advocating for your child is always important. And so I think if you know you have a family history, I would bring it up to your pediatrician and say, "Hey, I had hip dysplasia as a child, or my sister has hip dysplasia. I'd like to have my child screened." And the right time to typically get an ultrasound around 6 weeks of age. There's some reasons for that because if you do the ultrasounds very early, you often will get what we call false positives. You'll get some hips that look a little shallow, but if you give it a few weeks, they'll look totally normal. So you don't want to get like, too stressed out about something that isn't actually real. But most hips should be pretty normally shaped by 6 weeks of age. And so we typically recommend screening at 6 weeks of age if it's just a screen. Now, totally different if the hip is abnormal. If the hip is abnormal, feels abnormal, that should be looked at earlier. But if it's a pure risk factor screening, like again, mom, aunt, or whatever has a family history of hip dysplasia, then they should be screened around 6 weeks. I think one of the tricky parts, quite practically, is figuring out like how much family history is family history, right? So, does a grandmother who you don't even know if they were in a brace or if they had surgery, like, is that family history? I don't know. Is an aunt or a third cousin family history? It's hard. But if it's like mom had surgery for hip dysplasia or sister was in a brace for hip dysplasia, that's pretty strong family history. But where you draw the lines on what's strong enough family history is a little tough.
Makes sense. What tips would you give parents with children who have hip dysplasia?
Um, I guess a couple. The first thing I would say is to kind of take a breath because I think sometimes it can be very, very stressful. These are typically, these are obviously, well, I would say there's also kind of two categories. So I guess I'll talk about the infants maybe, and then I'll talk about maybe the older patients. But in the infants, usually these are new families because they're obviously have young babies. People are often stressed out. It's often firstborn girls, so that's a risk factor. So these are typically like first kids. So families are always a little bit more stressed than the first child, and so it's a really anxiety provoking time in people's lives. They want to get everything right as a parent, and then it feels like 4 weeks in you already have a kid that has like a problem, and that's really hard, I think, for families to process. So the first thing I would tell you is like just take a deep breath. It isn't cancer. It's very treatable, especially in a baby. We have to treat it, and it's a slight inconvenience. A brace is not the most fun thing you want in your baby pictures, but in the grand scheme of things, it's very low risk, extremely effective, and will most times solve the problem, right? So most hip dysplasia, even if it's there, can be really effectively treated early in life with braces, harnesses, and not having surgery. Okay, so the first thing I would tell you is take a deep breath. Um, the second thing I would say is, is it is an investment. So again, I do have some families that look at me and they're like, but do they have to wear this harness or do they have to wear this brace? Like it just looks terrible or it looks like it's bothering them. I hear it. I get that. Again, you have a child and this is not what you expect a newborn period to be like. But I would say like investing 4 weeks, 6 weeks, 8 weeks in a brace at the age of 3 months can basically cure the problem as opposed to having an issue where you're like chasing your tail, having surgery later in life. So as much as families may not want this, the ROI is so high. Like it's just such a relatively small investment. It's hard to see at that time, but it'll pay huge dividends later in life. And it's very hard for me to explain to a 35-year-old mom, a new mom, of what it would be like when that child is 25, right? That's just such a hard thing for people to get around there, unless she herself has hip dysplasia. Then it's easy, right? Then she's like, oh yeah, my hips hurt. I know exactly what we're trying to avoid. Those are easy ones for me to say, like, I think we should wear this brace. Um, and then the third thing, if you do happen to be that patient that has a more complicated situation, hasn't responded to a brace, may need surgery to get the hip to go back in, I would say it absolutely you want to go to a place that has experience. These are the kind of surgeries that the first shot is always the best shot. So, it's not like, oh, well, we'll try it here. And if it doesn't work, we'll go there. Like, no, you want to go to the best place first because these surgeries become, I mean, I won't say they're easy, but they're routine. We do a lot of them, or lots of places do a lot of them. But if you're doing revision surgery, everything becomes more complicated, and then you're kind of always trying to get back to where you were, and it's often hard. So I would say you want your first attempt to be the best attempt, to kind of make everything else that comes after that, better. Um, in teenagers and young adults, I think dysplasia is, a challenge because again, now we're not talking about braces anymore. We're talking about potentially bigger things, and I think that's it's a bigger pill to swallow. Um, I would say that my advice is also, take a deep breath. Not everybody that has hip dysplasia, has to have surgery. There are plenty of patients who, if they strengthen their muscles, if they control some of their activities, may be good. There's huge variations to severity of hip dysplasia. So people read online, they're like, oh my God, my hip's going to be shot in 2 years. That may be true, may not be true. It depends a little bit on the severity of the dysplasia and how shallow is shallow and so on. And then I would say same kind of thing. If you do end up being at the point where you're at the point where the symptoms are bad enough that you've tried non-operative treatment hasn't gotten better, then same thing. I think you want to go to a place that has a lot of experience to take care of you. This is one of
Oh,
those operations that I'm sure you know, Ashley, that PAOs it's concentrated in centers. There are very few people that have high volume, but those people have high volume. And then kind of you may have other people scattered that do a few here and there, and that's probably not the place that you want to end up being.
oh, I completely concur on that. My first PAO personally was not done correctly, and I spent the next better part of a decade chasing hardtails trying to do it, and I didn't know any better. It was
Yeah.
2009,
Yeah.
so it was just at the time we didn't know a lot.
Yep.
Social media wasn't very helpful at the time.
Yeah.
So yeah, it's very difficult. It is to kind of almost like it basically dig yourself out of a hole.
Yeah, it's a really technically challenging operation, and it's one of these things like people that do a lot of them do them well because they do a lot of them. But if you
Yep.
do them here and there, it's very hard to be really good at it.
Yes, I definitely agree on that. Can hip dysplasia be prevented?
Yeah, at some level, I mean, the genetic stuff, obviously you can't change. If you get born with a predisposition, you can't change the fact if you're a firstborn. You can't change the fact if you're a woman, but there are some modifiable things. So the one that really jumps to mind the most is swaddling. So we do know that swaddling or binding the legs tight with the legs out straight, so kind of like that papoose position. I tell people like a burrito wrap where you're just kind of completely out straight, which some people do in the United States, and certainly some other countries do. The classic is the Native American kind of papoose wrap. Um, those are detrimental for hip development, and that's been shown very nicely in several animal studies and obviously in some epidemiologic studies as well. So, that's where this whole move of hip healthy swaddling has come through a lot of work that Chad Price has done at the International Hip Dysplasia Institute, really educating people about how to swaddle safely, how to create that M position, which is the knees brought up to the chest so that the patient looks like an M. That's a safe position. Baby wearing and understanding that if you have the legs around the mother's body in that M position, that's actually a very safe position for hip development. So I would say that there are some modifiable risk factors that we can minimize with good education for our new families. But there's probably some genetic aspects that we can't.
Yeah. Do you have a most memorable case in your tenure at Children's Hospital?
Um, wow. I don't know if I do. I really have a lot of them. I mean, if I were to give you my camera, I would see all these pictures on the sides of all these kids that I've operated on. I think I would say maybe I'd answer that the kids that I really love. I mean, I take care of a lot of hip issues, but I would say the things I really love taking care of the most are like my 18-month, 2 and 3 year old kids who have dislocated hips and are walking with a limp, and they're you know they're savable, right? You can make them better, and you can make them better for 30 or 40 years, hopefully even longer than that. But the families are very appreciative. The kids are sweet, and I really enjoy that. And I think in terms of specifics, really specifics, I am challenged by revision surgery because those are very hard operations. But I think I also get the most satisfaction out of that is taking a situation which is kind of turned out not so great and then trying to make it better. So I don't know if that's an answer to your question, but
Oh, that's very good. Thank you. And our final question is when you're not working, which I'm sure is often quite a bit, what do you like to do in your off time?
several things. So I have 3 kids. I have a 12-year-old, a 10-year-old, and an 8-year-old. So, and my wife's a surgeon, so we are busy running around all the time trying to get them to sports. So they're in that like I'm the dad Uber, basically. I just need to drive my kids places, and so but I enjoy it. I love watching my kids play sports and be active and out in the field. So regardless of the outcome, it's really fun for me, and I like coaching their sports and being present as a dad. That's really important to me. And then my two hobbies is I love distance running. I run marathons and enjoy doing that. And hopefully my hips will hold up for a few more years of me doing it. But I do love distance running, and compete against myself in my own times and things like that. But I enjoy that. And then I love to garden. So I love to grow vegetables. I'm not a flower gardener. I'm a pragmatic gardener. So I got to grow stuff I can eat. Carrots, tomatoes, nothing better than a homegrown tomato. And so I love this time of year. It's just great when it starts getting warm on the East Coast and we start thinking about planting peas, and so it's fun.
I love that. That's very cool. Well, we greatly appreciate your time. And thank you, everyone, for joining in. And we look forward to seeing you next time.
Thanks,
Thank
Ashley. It's
you.
been total fun. You're doing a great job with this organization. I really appreciate all that you do for advocacy, and so it's really a pleasure to be a part of it.
Thank you.